In the name of the Father, and of the Son, and the Holy Spirit, my dear friends, today's topic is very interesting and very principled. It's a PCI, Percutaneous Coronary Intervention. I want to clarify some very important points that's absolutely necessary for you. So, are you ready? Take your pens, papers to make the notes, my beloveds, and let's go. Let's go. So PCI, angioplasty, percutaneous coronary intervention, has revolutionized the treatment in coronary artery disease. That we know that it's more than just a procedure. It's a field rich with evidence, technology, and critical clinical decision making. That's everything is okay. But the fact, the patients with STEMI, what STEMI is ST elevation myocardial, ST segment on ECG, of course, ST segment elevation myocardial infarction, STEMI. So for patients with STEMI, PCI is the gold standard. It's a gold standard treatment, so-called primary PCI. So the international recognized goal is to achieve door to balloon times of less than 19 minutes. What does it mean? It's so-called therapeutic window. So we have to understand the therapeutic window of STEMI is 2 up to 6 hours. What does it mean? So therapeutic windows is the best time to make your procedure, intervention. 0 point, it's a beginning of heart attack. It's a beginning of angina. And 6 hours is the upper limit. So red line. After that, deadline. It's futile. Door to balloon time means, so the time the patient enters is a public health actually notion, definition. So a patient enters into the hospital, so door, and to balloon means to ending of your stent built-in. Okay? So door to balloon time is less than 19 minutes. So don't confuse these two therapeutic windows if you want. So therapeutic window largely is the beginning of STEMI 0 to 6 hours. So best time for intervention and PCI. And door to balloon time means entering to the hospital and end of your balloon stenting. So STEMI, as we know, is caused by a complete and sudden occlusion of coronary artery due to erosion of unstable, small, not visible in coronary angiography, routine coronary angiography plaque. So leading to transmural myocardial necrosis. So we see STEMI, next day we see QMI. So myocardial necrosis is what? It's a death of heart muscle, myocardium. So the door to balloon time, so is the interval from the patient's arrival at the hospital to the moment that the occluded artery is opened with a balloon catheter during your PCI. Every minute of delay corresponds to irreversible loss of heart muscle. This 90-minute target is a major quality metric for hospitals and has been shown to dramatically improve survival and reduce heart failure and other complications of myocardial infarction. If a hospital is not PCI capable, don't have a cath lab, the goal is to transfer the patient to one that is, or if delay is too long, means more than 2 hours, 120 minutes, to administer fibrinolytic, thrombolytics, fibrinolytics, thrombolytics, clot busting therapy. Clot busting therapy. What's the importance of that? So in exam question for you, will often present in a patient with chest pain and ST segment elevation on ECG, and the question will ask for the next best step. So I repeat, remember that if the hospital is PCI capable. PCI capable means have a cath lab, catheterization laboratory. The answer is always immediate primary PCI, rescue PCI, primary PCI, or activate the cardiac catheterization lab. Know the 90 minutes benchmark and understand that is the most critical intervention for improving outcomes in STEMI. So you do, or if, for example, you can answer largely and more logically reasonable that I don't have a cath lab, so I administer fibrinolytic. And then why not, if it's possible, to transfer this patient to hospital that have cath lab. So it's an organization problem. It's actually administration problem. But the question like this will be on your big board exams. So next point, it's a dilemma. It's a great debate: drug-eluting versus bar metal stents. So there are two main types of coronary stents: bar metal stents, BMS, no classic metal stents, just stents, and drug-eluting stents, so-called DAS. It's both are abbreviation. BMS means bar metal stents, DAS, drug-eluting stents. So DAS are now used in over 95% of cases because they say that they are far superior at preventing renarrowing of the artery. Hello, Big Pharma. So details. So BMS, bar metal stents, a simple mesh scaffold made of stainless steel or cobalt chromium. It props the artery open. Its main weakness is a higher rate of restenosis, where aggressive scar tissue, so neointimal hyperplasia, grows through scarification, grows the stent struts, renarrowing the artery over mass. Actually, it's a normal response because it's a foreign body, and we encapsulate it with your connective tissue. Scar is a connective tissue. DAS. So BMS coated with a polymer that slowly elutes a drug. What is this polymer? It's a drug. With a polymer that slowly elutes the drug. Drug is, in vast majority of cases, is or a sirolimus or paclitaxel. Over several weeks to months, this drug inhibits, the cell proliferation that causes scar tissue formation, drastically reduces the rates of restenosis. But by what? By thrombs. By cicatrization, by restenosis by connective tissue. The drug also delays healing and the growth of a new healthy endothelial lining over the stent. And the problem is the issue. This leaves the stent exposed to blood for longer, increasing the risk of a dangerous blood clot forming inside. We will talk about that. Stent thrombosis. This is why a longer duration of potent antiplatelet therapy is required for DAS. So clinical exams will be like that. Be prepared to compare BMS, bar classic metal stents, and drug-eluting stents. So drug-eluting stents advantage low rate of restenosis, so less need for repeat procedures, and this disadvantage, higher risk of late stent thrombosis if antiplatelet therapy is stopped prematurely. Requires a longer course of dual antiplatelet therapy, so-called DAPT. DAPT, okay? So this DAPT, DAPT abbreviation. So after receiving a coronary stent, all patients must be placed on dual antiplatelet therapy, DAPT, to prevent stent thrombosis. What is this DAPT? DAPT consists of aspirin, we know that, plus P2Y12 inhibitor. So DAPT is the cornerstone of post-PCI pharmacology. A stent, we know that, is a foreign body, and placing it in an artery injuries the vessel wall, creating a highly thrombogenic surface. So this DAPT prevents platelet from aggregating and forming a life-threatening clot inside the stent. What is aspirin? Aspirin, we know that from pharmacology. Irreversible inhibits the COX enzyme, COX1 enzyme, blocking thromboxane A2 production. P2Y12 inhibitors block these receptors on platelets, preventing their activation. The main options are what we know: the clopidogrel, so-called Plavix clopidogrel, prasugrel, it's Effient, at the end. More potent, used in acute coronary syndrome. And ticagrelor, it's Brilinta, if my memory doesn't fail me. So more potent and used also in acute coronary syndrome. So the duration of this DAPT, of this dual treatment, depends on the clinical scenario and stent type, but it's typically 6-12 months for patients with ACS, acute coronary syndrome, receiving a drug-eluting stent, and can be shorter, 1 up to 3 months, in certain stable patients. I understand that risk of bleeding is also here. So premature cessation of DAPT is the single strongest predictor of stent thrombosis. What can be on your exam? As an exam question about post-PCI patients who need non-cardiac surgery will test your knowledge of this dual treatment, DAPT treatment. The key is to understand the high risk of stopping dual treatment early. Active surgery should be delayed until the planned so-called elective surgery, after that, should be delayed until the minimum DAPT duration is complete. These are the two major long complications of stenting: stent thrombosis versus in-stent restenosis. Let's understand that. So, two major long-term complications of stenting, but they are fundamentally different in their timing, mechanism, and presentation, and misunderstood by you. So don't be confused. So the question is, stent thrombosis, right? An acute catastrophic event. It's the formation of an occlusive blood clot inside the stent. Concerning timing, can be acute, less than 24 hours, can be subacute, 1 month, in 1 month. So from 1 day to up to 30 days. And late, more than 1 month. Cause, they say, most often caused by non-compliance with DAPT. DAPT means dual treatment, antiplatelet. Presentation presents as an acute restenosis with a very, very high mortality rate. Treatment, emergency PCI, if it's possible, of course. In-stent restenosis, a chronic gradual process, is the slow re-narrowing of the stented artery due to the growth of scar tissue, neointimal hyperplasia. Here, timing. So, in-stent restenosis typically occurs, don't they say, 3 to 12 months after the initial PCI, but sometimes it can be less than 3 months. But we say that 3 up to 12 months. Cause an exaggerated healing response, much more common with, they say, bare metal stents. But anyway, presentation presents at the gradual return of stable angina, stable angina, so chest pain with exertion. It rarely causes an acute heart attack. Yes, rarely. So treatment, usually another PCI, sometimes bypass, often with a DES, drug-eluting stent. And clinic exam is scenario. So be able to differentiate these two types. A patient who stopped, for example, their clopidogrel 2 weeks ago and presents with STEMI has stent thrombosis. A patient who had a just stent, BMS, barometric stent, 8 months ago, and now has returning chest pain on exertion, likely has in-stent restenosis. Now PCI versus CABG. For patient with complex multi-vessel coronary artery disease, coronary artery bypass grafting, CABG, surgery is often superior to PCI, especially in patients with diabetes. The landmark syntax, also abbreviation, CYNTX, syntax trial compared PCI using early generation drug-eluting stents with CABG surgery for patients with 3-vessel or left main coronary artery disease, left main. So the results showed that for patients with complex disease indicated by high syntax score, CABG resulted in a lower rates of death, myocardial infarction, and repeat revascularization at 5 years. So why is CABG better for complex disease? A CABG, especially mammalian with mammalian graft, CABG bypasses the entire disease segment. Bypasses. That's why bypasses the entire diseased segment of an artery, providing a more durable and complete revascularization. PCI is only spot treats individual blockages. Spot treats individual blockage. So diabetics tends to have a more diffuse, rapidly progressive disease, atherosclerosis, and they derive a particularly strong survival benefit from CABG over PCI. Importance of that. This is a high-level clinical decision-making question. Okay, so the answer to PCI or something like this, the answer to PCI or the CABG on your exam depends on the syntax score, that is, score reflecting the complexity of the disease. Just low syntax score, simple disease, one vessel disease, PCI is an option, PCI is an excellent answer. High syntax score, complex disease, or with diabetes, CABG is generally the preferred strategy. Now about stable angina, ischemia trial. In patients with stable ischemic heart disease, stable angina, an initial strategy of PCI plus optimal medical therapy doesn't reduce the risk of death or future heart attack compared to therapy alone. PCI primarily improves symptoms. For decades, it was assumed that unclogging a blocked arteries in a stable patient would prevent future events. The landmark ischemia trial proved this wrong. It randomized stable patients with moderate to severe ischemia to either an invasive strategy, so PCI CABG plus therapy, or a conservative strategy, that is therapy alone, with catheterization reserved for failed medical therapy, just for that. And the results showed no difference in hard endpoints like death or MI. The invasive group did, however, report a better quality of life and less angina. No, highly likely it's a placebo effect. So, what is the issue of that? This is a crucial concept, my beloveds. For a patient with STEMI PCI, especially in good time, in therapeutic window, of course, if life is life-saving, no doubt. For patients with stable angina, PCI is primarily, symptom relieving. The first-line treatment for stable angina is optimal medical therapy. Means aspirin, means beta blockers, means managing comorbidities, arterial hypertension, diabetes, etc. Statins, depends actually, etc. Okay, great. Kidney problem. The iodine contrast, so-called iodine contrast dye used during PCI can cause so-called contrast-induced nephropathy, CIN, contrast-induced nephropathy, CIN. Okay, so what is this contrast-induced nephropathy? An acute kidney injury that typically occurs 24 hours, 72 hours after the procedure, PCI procedure. The single most effective preventive measure is intravenous hydration. So this nephropathy is defined as a rise in serum creatinine after contrast exposure. This mechanism involves direct tubular toxicity from the dye and renal vasoconstriction. In my opinion, highly likely it's autoimmune response. The biggest risk factors are pre-existing chronic kidney disease, diabetes, and high contrast volume. The most important preventive strategy is to administer isotonic fluids, intravenous fluids, not like normal saline, before, during, and after the procedure to maintain renal perfusion and dilute the contrast. Dilute the contrast. Issue of that, clinical issue of that. Or exam question may ask, No, I don't know. You name it. How to prepare a high-risk patient. What does it mean, high-risk patient? Diabetic with creatinine or of 1.8 milligram on deciliter for a PCI. The correct answer is pre-procedural intravenous hydration. Hydration is the answer anyway for prevention of this problem. So the preferred arterial access site for PCI is shifted from the femoral artery in my time in the groin to the radial artery in the wrist. This is radial first approach significantly reduced bleeding complications. So the problem was that the traditional femoral access carries a higher risk of major access site complications, including life-threatening retrooperational hemorrhage, pseudoaneurysms, and large hematomas. Radial access avoids these risks. Because the radial artery is superficial and easily compressible against the radius bone, major bleeding is very rare. This has been shown in multiple trials to reduce major bleeding and even improve survival in some high-risk patient groups. It also allows for earlier patient ambulation and improved comfort. Knowing that the radial first approach is the modern standard of care demonstrates up-to-date knowledge. Associated with a low risk of bleeding complications, which is a primarily advantage. I don't know actually you will ask about that or not on your big exam, just know that. Next, advanced intravascular techniques like IVUS, intravascular ultrasound, and optical coherence tomography (OCT) allow cardiologists to see inside the coronary artery, leading to more precise and optimized stent placement. Angiography, so the standard X-ray imaging, is essentially 2D shadow, a luminogram, and can be very often misleading. So IVUS, intravascular ultrasound, sound waves to create a cross-sectional image of the artery wall, plaque, and stent. Actually, you can see in stable plaques as well with this technique. OCT, so optical coherence tomography, uses near-infrared light to provide extremely high-resolution images, allowing for detailed assessment of stent strut position and tissue coverage. These tools are used to accurately measure vessel size, assess plaque characteristics, ensure the stent is fully expanded and pressed against the vessel wall, and identify the cause of stent failure. So issue of that, this is a more advanced topic, and not in every hospital, of course, it's rare. Knowing what IVUS or IVUS intravascular ultrasound or the optical coherence tomography demonstrates a deeper understanding of modern interventional cardiology beyond the basics. If you answer in this manner, it will be excellent on your big exam. And about this diamond drill, for severely calcified rock-hard coronary lesions that cannot be opened with a standard balloon, an advanced technique called rotational atherectomy, rotablator, is used. So a standard balloon may not be able to dilate a heavily calcified plaque. And the rotational atherectomy uses a high-speed, very high-speed, diamond-coated burr that spins around 150,000 per minute rotation, per minute, 150,000. It works on the principle of differential cutting. It selectively ablates the heart in elastic calcified plaques while sparing the soft, elastic, normal vessel wall, they say. This drills a channel through the blockage, modifying the plaque so that the balloon and stent can then be successfully delivered and expanded. So this is another fascinating fact, actually. Knowing the rotational atherosclerotic exists and it's used for severely calcified lesions shows you are aware. of the tools used to treat the most challenging and complex coronary artery disease, my beloveds. That's all. That's it concerning this PCI topic. I suppose I clarified all the questions that were confused you on previous several board exams. God bless you. Don't forget to follow and subscribe my Dr. Y YouTube channel, as well as my private Dr. Y channel, Telegram. There are a lot of interesting things, not only lectures there. Anyway, actually closed lectures as well, that there are no more in YouTube. So all that you can find in my Dr. Y Telegram channel. How to find this Telegram channel? You type in searching mode. Same name, Dr. Y, WHY, without question mark, of course. Dr. WHY. You find the bot, you click start, you choose your plan, and we will talk about that. God bless.